Do you ever wonder why a baby might be born with unusual genital appearance, or why a child grows unusually fast? These clues can point to a rare condition called congenital adrenal hyperplasia, CAH, due to 3-beta-hydroxysteroid dehydrogenase deficiency. Imagine your body's hormone factory, the adrenal glands, as a kitchen with a recipe book. In this type of CAH, one recipe step is broken, so the kitchen makes too little of some hormones and too much of others. The result shows up as growth, skin, and reproductive changes that can be noticed early in life. The cause is a genetic mistake in the HSD3B2 gene, which provides instructions for the enzyme 3-beta-hydroxysteroid dehydrogenase. This enzyme is needed to turn early hormone precursors into the hormones cortisol, aldosterone, and sex steroids. The mistake is inherited in an autosomal recessive pattern, meaning a child must receive a faulty copy from both parents. If only one parent passes the defect, the child is just a carrier and usually stays healthy. Think of it like two halves of a broken key. You need both halves to open the lock, the enzyme function. Typical signs show up in newborns or early childhood. Ambiguous genitalia in newborn girls. Clitoris may look larger, or boys, penis may be smaller. Salt wasting crisis. Loss of too much sodium leading to dehydration, low blood pressure, and vomiting. Early rapid growth and later premature puberty signs. Pubic hair, voice deepening. Low blood sugar episodes because cortisol, which helps keep glucose stable, is low. Skin hyperpigmentation, darker patches, caused by excess ACTH trying to stimulate the broken adrenal gland. Ask yourself if a baby is unusually sleepy, vomits a lot, and has a salty taste in the mouth. Could the body be losing salt? That is a red flag for this condition. Doctors confirm the diagnosis with a blood test that measures hormone levels, low cortisol and aldosterone, high 17-hydroxyprogesterone, and elevated ACTH. A genetic test looks for mutations in the HSD3B2 gene. Treatment focuses on hormone replacement. Hydrocortisone to replace missing cortisol. Fludrocortisone, a mineralocorticoid to keep salt balance. Growth monitoring and sometimes sex hormone therapy during puberty to guide normal development. Parents are taught to give medicine at specific times, morning, noon, evening, and to recognize a crisis, vomiting, low blood pressure, so they can give an emergency injection of hydrocortisone and call for help. Because the disorder is genetic, the best way to avoid it is carrier screening for couples planning a family, especially if there is a family history. Prenatal testing, chorionic villus sampling, or amniocentesis can detect the mutation before birth. If both parents are carriers, they can consider genetic counseling to understand the 25% chance of having an affected child and explore options, such as IVF with pre-implantation genetic diagnosis. Recent advances include newborn screening programs that add 3-beta-HSD deficiency to the panel of hormones measured, catching the disease before symptoms appear. Researchers are also exploring gene editing techniques, CRISPR, in animal models to correct the HSD3B2 mutation, which could someday lead to a one-time cure. Additionally, long-acting steroid formulations are being tested to reduce the number of daily doses, making management easier for kids and families.